All right, we can go ahead and get started. Good evening, everyone, and welcome to our Pectus Excavatum Community Seminar. My name is Lacey Kapnich. I am a medical education specialist with Zimmer Biomet, and we are pleased to bring you this program. Our speaker tonight is Dr. Barry LoSasso. Dr. LoSasso is joining us from Paramus, New Jersey, where he is affiliated with the Pediatric Surgical Associates in New Jersey and is affiliated with Valley Hospital in Ridgewood, New Jersey. Dr. LoSasso has extensive experience in treating both adults and children with Pectus Excavatum. We will begin this presentation and conclude with a question and answer session. During the talk, please submit any questions using the Q&A feature. If you don't see it on your screen, click the three dots on the main toolbar of your page and enable it. Our training team will share your questions with our speakers at the end of the program. Since we are able to offer CMEs thanks to the Valley Hospital, I do have a quick disclosure that the Valley Hospital is accredited by the Medical Society of New Jersey to provide continuing medical education for physicians. The Valley Hospital designates this electronic activity for a maximum of 1.5 AMA PRA Category 1 credits. Physicians should claim only the credits commensurate with the extent of their participation in the activity. Dr. LoSasso, myself, and Ms. Tan have stated in the faculty disclosure form for the CME activity that his presentation will not include discussion of a commercial product or service. The presenters will disclose any unlabeled use of a product discussed today. The planners of the activity do not have any disclosures. Other persons who influence the content of this educational activity do not have financial arrangement with the manufacturer of a product or service. This activity is not supported by a grant. Members of the Valley Hospital Education Committee or CME staff who have the opportunity to influence the content of this educational activity do not have any conflicting financial interests to report. With all of that, thank you for being with us today. I'll go ahead and pass it over to Dr. LoSasso.
Good evening, and thank you so very much for sharing a little bit of your time this evening with me. I'm so happy to be partnering with Zimmer Biomet, and I'm very happy to be able to bring this information to all of you out there, most of whom are practicing in New Jersey and in the tri-state area, some maybe even beyond. That's the beauty of teleconferencing. We can reach so many more people using this technique. And I hope that this information will help you the next time in your practice you are treating or seeing a patient that has a pectus deformity. I'd like to spend a minute sharing with you this disclaimer that I am a member of the Zimmer Biomet teaching faculty, and that I have no financial disclosures to reveal. Today's agenda is going to include a short overview of pectus deformities, talk a little bit about some of the associated conditions, talk specifically about pectus carinatum, or pigeon-breastedness as it's sometimes called, as a separate entity, and then do a extensive review of Pectus Excavatum, during which we'll talk a little bit about the clinical research that supports the physiologic impairments that occur as a result of Pectus Excavatum, talk a little bit about non-surgical treatment options for patients who are young and have very minimal deformities, talk about what the standard of care has become for minimally invasive surgical treatment options, and then talk a little bit about how one cares for patients postoperatively, and then share with you some of the clinical research that has documented the improvements that these patients will achieve following the procedure. And then I'd like to share with you some of the patient education opportunities that exist on the Zimmer Biomet website. Let's just start with what is a chest wall deformity. The normal chest should be about twice as wide as it is deep. And Pectus excavatum, or sunken chest, sometimes called funnel chest, is where the sternum gets ever closer to the spine as the chest sinks. Pectus carinatum is the reverse of that condition, where the chest protrudes. Classically, it's bilateral, but a more common form is when it occurs unilaterally, more often on the right than on the left. It's important to understand what the underlying anatomy is with regards to pectus deformities, whether you have a sunken chest, excavatum, or a chest that protrudes, carinatum. Essentially, the problem is simply that the cartilaginous ribs, which are to either side of your sternum, are genetically predisposed to growing abnormally. And as they grow abnormally, the sternum either protrudes in carinatum or it sinks in excavatum. The overall condition is much more common in males than females, almost 4 males to every 1 female. The incidence is fairly high. 1 in every 400 people on the planet have some form of pectus deformity. So on a sunny day here in New Jersey, down at the shore, you can walk down the beach and be guaranteed that you'll see someone with some form of pectus deformity. The more common time of presentation is during the pubertal growth spurt, but it can be seen in about 40% of patients, even at the time of birth. Pectus excavatum is the much more common form of pectus deformity, seen in about 75 to 85% of cases, and Pectus carinatum is seen in far fewer, about 15 to 25%. And of course, with excavatum, the treatment is more surgically oriented, and with carinatum, the treatment is more non-surgical, but we'll get into that in just a second. We'd like to talk a little bit about those of you who are in the primary care field and are seeing these patients with their families, or are in the adult milieu and are seeing patients coming in and complaining of their chest wall being different than what it might normally be, and give you some information that allows you to sort of educate the patients and reassure them and begin the process of evaluating them and selecting patients who might benefit from further treatment. So patients tend to have family history. The inheritance is generally autosomal recessive, and about 40 as high as 50% in some studies that I've read have a positive family history. So remember then, it's genetics plus growth, abnormal growth, that is, of the cartilaginous ribs that lead to the condition. An associated condition in about a third of patients is scoliosis or spinal deviation. Of course, the pictured case is a severe case of scoliosis, but it's not hard to imagine that as the front of the chest either sinks or protrudes, that forces on the back of the chest wall, namely along the spine, could lead to deviation. Remember, the chest is no more than just a ring. And as the front deforms, either forward or back, forces are then generated along the spine that cause this deviation. More often than not, it's minor. It generally does not require separate orthopedic correction of the spinal deformity, and often with correction of the anterior component of the deformity, meaning the pectus deformity, you can either improve or at least arrest the further progression of the spinal deviation. There's also the association with pectus deformities of either kind with connective tissue disorders. Now, this is very uncommon. So if you have a patient with a pectus deformity, there's probably a 1 in 500 chance that they have a connective tissue disease. The reverse, however, is quite common, meaning if you have a patient with a connective tissue disease, the vast majority of those patients will have a chest wall deformity. The approach to the patient with Pectus excavatum and no family history of connective tissue disease is to first inquire about that and then to screen for that. That screening is physical exam, of course, and seeing if any of the stigmata of connective tissue disease is present. And if so, then further genetic testing would be indicated. Also, one can do a screening echo of the heart, an echocardiogram, looking for aortic dilatation, which would be one of the more common associated findings with Marfan syndrome in particular, and also an ocular exam, an ophthalmologic exam, to determine where the lens of the eye are located, can be an additional screening test to rule out connective tissue disease, Marfan's in particular. Ehlers-Danlos is a more rare connective tissue disease, but there are patients with Ehlers-Danlos that have pectus deformities. Having a connective tissue disease does not rule out the correction, the surgical correction of the pectus deformity if that deformity meets other standards of care that would indicate that the patient would benefit from correction. What is important is to ascertain the pectus patient that has a connective tissue disease. So like things like aortic dilatation can be identified and monitored over the course of a lifetime. In addition, there are other cardiac conditions, the most common of which is mitral valve prolapse. That can be seen in upwards of 25% of patients with Pectus excavatum. And for that reason, echocardiography is a very important part of the evaluation of a patient with a pectus deformity. It's important for patients to understand that it's not just the deformity itself, but its cardiac implications that require further workup. It's also a good way to ease the minds of patients who are coming to see you by telling them that this is an important evaluation that needs to be done. Whether or not you go on to surgery and correction of your deformity, it's important to have the information that is available through working a patient up with Pectus excavatum or Carinatum. Let's talk about Carinatum first. The good news about Carinatum is that generally symptoms are very mild, that they most often include pain, and in my experience, that pain is associated with periods where the chest is growing. And I've always considered the growth creating stretch of the chest wall that is causing that pain. They can have other symptoms that mimic excavatum, like shortness of breath or palpitations, but that's less common. The most common symptom, in my experience, is chest pain. What I tell families who come to see me with Pectus carinatum is that there's no internal pathophysiology that results from this form of Pectus deformity. That's enormously comforting to families to know that even though there is a cosmetic deformity, that there's no internal abnormalities that results from carinatum. But it also is important for the families and patients to know that Pectus carinatum is a marker for potentially connective tissue disease, and workup specific for connective tissue disease needs to be pursued. And that, in my practice, includes echocardiogram and ophthalmologic exam. The real problem with carinatum is that it deforms the chest wall. So many patients come to me, and fairly early in their development, very concerned about their chest wall and the low esteem that often is associated with it. It's very gratifying to me to be able to tell patients with this condition that there is a non-surgical and very effective treatment for carinatum, and I'd like to share that with you. It's called an external brace, and this brace needs to be considered when a patient with carinatum presents to you. The success rate is very high, and it requires compliance. I tell all the teenagers that the brace doesn't work under the bed or in the closet. It has to be worn, but when it is worn, it is enormously effective. It requires up to 24-hour, 7-day-a-week wearing of the brace initially, but that can be lessened as the chest starts to conform to the pressures of the brace and the deformity starts to correct itself. Generally, it takes upwards of 6 to 12 months to correct the deformity using this external brace. But it's interesting that the brace and the internal bar are doing the same thing, just in different directions. It's force over time that causes the cartilaginous ribs to conform to those forces, those pressure forces, and undergo the biologic process of remodeling, which literally reshapes that portion of the chest wall which is growing abnormally. It's very effective. It's most effective when it's done below the age of 18. When you get into the upper teen years and into the 20s and 30s, the chest wall is much more rigid and less likely to respond to external bracing and pressure. In the case where you have an adult patient who, for whatever reason, did not undergo bracing as a young adult and comes to you with a carinatum deformity, there is still a treatment option. That option, however, is surgical. And the operation is called the Ravitch procedure. It's been around for, the better part of 70 years. And it's a tried and true correction for carinatum that can't be braced. However, it requires an incision across the anterior chest wall, a deconstruction, if you will, of the chest wall, in which the cartilaginous ribs, which are abnormal, are exposed. Those cartilaginous ribs are removed, and the sternum is repositioned such that the contour of the chest at the end of the procedure has been normalized. Excavatum is a completely different condition, and there is pathophysiology with Pectus excavatum. There are also symptoms. So I want to dispel any misunderstanding that might exist within the audience today that Pectus excavatum is purely cosmetic. It is not. These patients have pathophysiology, and they have severe, sometimes severe, and significant symptoms. The most common symptom of which is shortness of breath or dyspnea with mild exercise. Generally, it's any aerobic activity, whether it's running or swimming or biking or hiking or doing anything at elevation that will bring on this shortness of breath. In addition, they tend to have exercise intolerance, or put another way, a loss of endurance, and an inability to keep up with their peers, which is a great way of eliciting history from a young adult or child as to whether or not they're able to keep up with their teammates or their classmates when they're doing aerobic activities like running the mile and being timed for the running of the mile in gym class, or whether they're participating in sports where aerobics are very, very important, like basketball or track and field, and there is a sense that they can't keep up with their peers. It's a very important and subtle way of asking the most important question of the patient, which is, are they starting to have symptoms consistent with the pathophysiology of both compression and displacement of the heart, which is pictured in the diagram. Less common symptoms can be worsening fatigue, palpitations, tachycardia, fainting, dizziness, some chest pain. Some have chest pain with aerobic exercise. But last and definitely not least is the psychosocial impact of the deformity itself. Patients becoming depressed, withdrawn, sort of fixated on their poor body image. That is something that happens quite commonly with these patients, and it's heartbreaking when you see this in your practice. And it's important to allow patients who are exhibiting these psychological symptoms to know that that there is hope, that correction of the deformity can improve their sense of well-being and their sense of self. So there's been a lot of research on the effect of sunkenness on the physiology of the heart and lungs. I'd like to share some of that with you. Some of this data that I'm presenting to you now comes from Europe, from Hans Pillard's group in Denmark, who has done a tremendous amount of Pectus surgery and looked at their Pectus patients very critically. And what they've been able to see is that if you compare patients with moderate to severe Pectus deformity to normal controls, you see that these patients have decreased cardiac output and decreased cardiac stroke index, which is simply because their hearts are being compressed and being displaced. If you think of the heart, the more anterior chambers are the right atrium and ventricle, and the compression by the chest wall on those chambers are what decreases cardiac efficiency, especially between the heart and the lungs on the right side of circulation. It's that effect that causes many of the symptoms that we just reviewed. In addition, if you look at pulmonary function testing, you'll see in a distinct number of patients, most of whom have severe deformities, that there are pulmonary function abnormalities. There's lowered FEV1, or forced expiratory volume in 1 second. There's lowered forced vital capacity, or FVC, and decreased lung capacity. Now, I want to make this point that most patients, even with severe deformities, have normal pulmonary function tests. So it's the minority of patients that have abnormal pulmonary function tests, but all patients with Pectus Excavatum in particular need to have pulmonary function testing, and you will find that about 40 to 50% of them will have abnormal studies. It's important to understand that this is more than a cosmetic defect, but it's not to underappreciate the psychological effect that this has in terms of anxiety, negative body image, depression, socialization, and a sense of stigmatization that is very profound. And this effect tends to worsen as patients age. I find that those patients who are most affected psychologically by their deformity are the patients that come to me later in life, like in their late teens or early 20s, and are very, very affected psychologically in large numbers by the deformity. What are the non-surgical options? Because there are some non-surgical options for Pectus deformity. First and foremost is that if you have a very minor deformity and you're very young, sometimes just doing breathing exercises, deep breathing, and encouraging patients to participate in challenging aerobic sports can sometimes help in continuing to allow the patient to function well in early childhood. So if a patient comes to you at age 4 or 5 and has a minor Pectus excavatum deformity, encourage those families and that patient to participate in aerobic exercise. It is always helpful to do so. As that deformity worsens, because that chest wall begins to develop in an abnormal way, then you can escalate your treatment option to include the VacuumBell. This was first described in Europe, in fact, in Switzerland, and it's very popular in Europe as a primary mode of treatment that is used in the very young. It's a non-surgical treatment. It's a device that's placed over the chest. Suction is created, and as the chest wall is applied, negative pressure is applied to it, the chest rises, and by repeating that a couple of times every day over a long enough period of time, some correction of the deformity can occur. But I want to caution you that this is not a definitive treatment for patients who have deep deformities and present to you older older in life, like in their late teens or early 20s. When a surgical pectus repair is necessary, how do you determine that? And that's this slide. This slide shows a CAT scan. We've moved more towards using MRI to determine severity. But the Haller index described by Alex Haller when he was at Johns Hopkins Hospital in Baltimore is sort of in a simple and yet ingenious way of attributing a mathematical quotient or number to the deformity. As I said earlier, your chest wall is about twice as wide as it is deep. So if you divide the smaller front to back number, you divide the longer side to side number by the shorter front to back number, you have 2 or thereabouts, 2 to 2.5 if you're normal. As the AP distance decreases, the fixed larger side to side distance remains the same, and the quotient or ratio increases. When it exceeds 3.25, then you have a deformity that meets one of the more critical standards of care necessary to determine that the severity would benefit from correction. It's very important to understand that MRI has supplanted CT, and in addition, we've been using cardiac and chest wall MRI at the Valley Hospital to further discern the effects of sunken chest. And what's interesting is if you do both a chest wall and cardiac MRI, you start to see not only the mathematical severity index, but you also start to see how a given index is affecting right-sided heart circulation. And that's very exciting. And it also helps us to further define severity. So we are pioneering the use of cardiac MRI in further evaluating patients with regards to severity of the deformity. Cardiology evaluation is always important. You must determine whether or not there are any structural abnormalities of the heart. To use the example of the aorta and the mitral valve, it's important that all these patients have cardiac and cardiologic evaluation, and it's always important for them to see a pulmonologist and have pulmonary function testing. So I present as a surgical option the open repair, but this is more of historical interest than really the standard of care in the 21st century. The Ravitch operation is seldom necessary in the setting of Pectus Excavatum deformity. It's an open operation. It involves the deconstruction of the chest and removal of some of the native tissue of the chest wall. And it's actually, in my opinion, contraindicated in the treatment of patients with Pectus deformity, Pectus excavatum deformity. It's not an optimal approach to patients who need their chest wall corrected. But what is optimal is the minimally invasive operation that was pioneered by Donald Nuss. Dr. Nuss began his quest for a better operation in the mid-'80s. He perfected the technique and developed the hardware yeah, from the mid 80s until the late 90s. He presented his first 45 patients in 1998, and it was really the beginning of the paradigm shift with regards to how Pectus excavatum is best treated. The operation always involves using a thoracoscope. Its minimally invasive nature allows the use of the thoracoscope and small instruments to make small incisions and create subcutaneous and internal transmediastinal tunnels into which a bar is placed. The incisions are made on the lateral chest wall, where the arms lying naturally against the sides of the chest cover the incision quite nicely. And the incisions are about 1.25 inches on either side. And then there's a 5-millimeter incision made that allows visualization internally. The bar is either shaped by the surgeon, if the bar is stainless steel, which is the more common bar used, or in patients that have a metal allergy, then a titanium bar is used, and that bar is then shaped by Zimmer Biomet and is inserted by the surgeon pre-shaped, okay? The operation internally is essentially to create a space between the sunken chest and the heart such that the bar can go below the deformity and above the heart, and therefore lift the chest anteriorly towards the ceiling in a patient who is supine. The bar does that by laterally pressing down on the bony ribs laterally, creating lift in the center of the chest. So imagine that the lateral part of the bar is under the skin of the chest wall, and about at the point where the mid-clavicular line would be, the bar goes internal between the ribs through the intercostal muscle, and then intrathoracically across the mediastinum, below the deformity, and above the pericardium. This can all be done safely because it's done under magnification and under thoracoscopic control. Once that space is created, the bar then goes in a concave fashion and then is flipped into a convex configuration, then lifting the middle of the chest. The metal bar then has to be stabilized, and that's done through stitching of the ends of the bar directly into the lateral chest wall musculature. There are many different ways of further stabilizing the bar. I do it in the classic way that Dr. Nuss taught me, which is to use a stabilizer, a bracket on the end of the bar to further prevent the bar from rotating. And on the side opposite, the side I put the stabilizer on, I put stitches around the bar and anchor it to a rib using a special instrument and the thoracoscope to do that. I've never had any bars migrate because I use this technique of further stabilization of the bar on both sides. The bars stay in for, in my practice, 3 years, sometimes longer if I put a bar in to a patient who's very young, like 12 or 13, especially in boys, who then 3 years later at 16 may still be growing significantly. And I like to avoid removing the bar while there's still significant growth going forward. I like to wait until they are growing at a rate of less than an inch a year before I remove the bar. Put another way, I measure growth in height, and if the growth is less than a half an inch in the 6 months prior to the scheduled time of removal, then I feel I can confidently remove the bar and not have any recurrence. The benefits of the Nuss procedure are simply put that you're doing a less invasive operation that's more physiologic in its ramifications. It reshapes the chest without removing any of the components of the chest wall. There's shorter operating time, there's less blood loss, and there's reduced overall trauma to the body as a result of the more minimally invasive procedure. Postoperative care, I think, is an area where we have really made the most advances in the last, 10 years that I've been doing this operation. I was the first person to go to Norfolk and learn this operation from Dr. Nuss. I've been doing it for 20 years. I've done over 1,000 cases. And the thing that's most gratifying and the thing that's changed the most, in my opinion, is that we've gotten better at treating the discomfort that is associated with this operation. Clearly, in correcting the deformity, you're taking someone that's sunken, and then the time it takes to literally flip the bar 180 degrees, you place them in a corrected position. That's a lot of force and a lot of stress on the chest wall. The trauma of that in terms of pain is an area that we've gotten very, very good at dealing with. What in my practice I do is I use long-acting local anesthetic, and I do a series of rib blocks that I can do very precisely using the thoracoscopic approach and using long-acting liposomal bupivacaine. That gives me rib blocks that can last upwards of 3 to 4 days. It's during that time that the body accommodates the forces of the bar. And if you can get the patient through that phase with good pain management, then at the other end of that interval of time, the patient is able to have their pain managed with things like, non-steroidal anti-inflammatory drugs and other non-narcotic medications, which are very much less problematic and very effective if you can get the patient through those first few days. So it's important for patients who are treated through using the Nuss procedure that the person doing this is very skilled and works within a multidisciplinary team setting that involves pain management specialists. That resource of pain management using multiple drugs working synergistically both more effectively treats the discomfort of the Nuss procedure and minimizes the need for using narcotics. This is, I think, one of the most exciting areas of advancement that we've been able to see in this field in the last 5 to 10 years. In my practice, once patients are have undergone the procedure, we transfer them extubated to a critical care unit where there's ongoing monitoring and bedside one-to-one nursing. And that is in place for the first 24 to 48 hours. Most of these patients are able to go home on post-op day 3, if not 4, and they go home on a regimen of a neurolytic such as gabapentin, a non-steroidal like Motrin or Celebrex, a anti-spasm medication like Valium, and usually no more than a week's worth of hydrocodone is more than adequate to get them through the most significant phase of pain management for these patients. Most of my patients only need a day or two after their discharge from the hospital of some narcotic pain medication to get them through to a point where they could be managed totally and very comfortably without narcotics at all. In the initial first weeks after surgery, I encourage my patients to walk, to try walking starting at a rate of about 5 to 10 minutes 3 times a day. And by a month following surgery, they're generally able to walk around 30 minutes 3 times a day and do incentive spirometry in concert with their walking. At about a month, sometimes at 3 weeks, depending on the individual, I start them into a formal physical therapy program. And if you go to my website at nussprocedure.com, I have a video that illustrates the physical therapy program that I use with my patients. It's extremely important for patients who are undergoing this procedure to know that physical therapy, generally twice a week for 8 weeks, starting somewhere between 3 to 4 weeks after surgery, is critical in getting them back to full functioning and the quality of life that they had had prior to the surgery. Generally, by the time patients get to 3 months post-op, they can do non-contact sports, return to full athletic activities. I just ask that my patients not do competitive contact sports until they reach 6 months post-op. But frequent walking, deep breathing, etc., are very, very important adjuvants in those first few weeks following the procedure. Bar removal usually occurs at 3 years, though it can occur as early as 2 years if the patient is having issues with the bar that are affecting quality of life. This is an outpatient procedure for most of us doing this work. It doesn't require a hospital stay, and access to the bars is through the lateral chest wall incisions that were made during the original procedure. So it's patient, It's about 2 to 3 hours to do, and the patients are fully recovered from it, generally in 2 to 3 weeks. What are some of the improvements that we've been able to document in patients who have undergone the Nuss procedure? Well, clearly, by expanding the chest and relieving the compression and displacement of the heart, some of that decrease in cardiac efficiency that I described earlier has been reversed, such that increase in cardiac output and stroke volume is seen in many of these patients. And they start to perform better. They start to enjoy aerobic exercise more, the quality of their life improves, and their ability to do activities which require aerobic endurance increase. In addition, in many studies, there's been shown that there's improvement also in pulmonary function testing. If you go to the website, the Zimmer Biomet website, there's an enormous amount of patient education information that you can direct your patients to so that they can do their own vetting of what might be helpful to them in terms of knowledge and information regarding treatment options. So I would encourage you to direct your patients for education to the Zimmer Biomet website. And also my website, which is nussprocedure.com, has an enormous amount of information for patients with regards to education. I also would like you all to know that there are very good patient-centered resources on the web that serve as support groups where patients support other patients. Pectus.com is one of them, but there's many websites that are patient-centered, where patients are helping to educate patients. And I would encourage you to inform your patients of these resources that are patient-generated. I want to thank you for your attention tonight. I hope you found this information valuable, and I hope together we can educate patients as to what a pectus deformity is and how those patients can be benefited through thorough and complete evaluation, and if indicated, operations and interventions that can improve the quality of these patients' lives. Thank you again for partnering with us here at Zimmer Biomet and with me tonight. It's been a pleasure spending this time with you. Thank you very much for your attention. And now, if you have any questions, I'd be more than happy to answer them.
Thank you, Dr. LoSasso. As you said, we will now start our Q&A session. So attendees, please feel free to submit your questions using the chat or the Q&A feature using the circle with the 3 dots at the bottom of your screen. Dr. LoSasso, it looks like we have one already. It says, are there any research studies that support efficacy of brace controlled double blind? How do we order the brace?
That's a great question. To my knowledge, there are some studies that look at the benefits, both in terms of mostly in terms of satisfaction with regards to bracing. I don't know if there's anything that's double-blinded per se, but I want to assure the person asking that question that the brace is extremely effective. And there is a individual that I personally use that is very experienced in bracing. And if you want to reach out to me through my office, I'd be more than happy to pass along to anyone who wishes to avail themselves of the bracing resource that I personally use. I'd be more than happy to share that contact with a given provider. But in general, regardless of who you use, you want to make sure that they're experienced in making braces specifically for pectus deformities, right? There's a lot of orthotic providers out there, but you want to make sure that in their practice, they're seeing a lot of Pectus Carinatum patients, and they're experienced in doing so. The reason I say that is because these braces are fairly simple in terms of their concept, but they're fairly, it's very important that the person who's making the brace is experienced and can fit the brace specifically to the deformity, unique deformity of a given individual patient. So the actual configuration of the chest plate on the deformity being done precisely is exceedingly important. And that's where an experienced brace manufacturer or orthotic specialist is critical in getting the best outcomes for the patient.
Thank you. We have some more questions rolling in. How do you treat patients with failed surgical repairs?
Well, that's a very difficult question to answer simply. I would say failure is sometimes in the eyes of the beholder. So if a patient comes to you and says, I've had a fill in the blank, Ravitch procedure or Nuss procedure, and the patient feel that the result has not been optimal, then it's extremely important for that patient to first be seen by the treating physician, the physician who did the original treatment. Because often patients are reluctant to go back to the original provider and share with them their concerns. Often, if they do that, more often than not, the concerns of the patient can be addressed. If that's not acceptable to the patient to go back to the original provider, then sending that patient to somebody who's extremely experienced is exceedingly important, because essentially the way I approach such a patient is I completely work them up once again. Your options are somewhat limited if the patient had a Ravitch operation, because the Ravitch operation changes so significantly the anatomy of the chest wall that often the Nuss procedure is not safe to do in a patient who's had a failed Ravitch. Not in all situations, but in many situations. And so a skilled and experienced surgical provider needs to evaluate these patients and needs to start from the beginning in doing that evaluation. And this can be a very, very difficult conversation to have with a patient who has had a true failed operation. In terms of the Nuss procedure, depending upon the reason for the failure and the severity of the persistent deformity, I would just say that redoing a Nuss procedure is an option. I have redone Nuss procedures. It can be done, but it is exceedingly more difficult and dangerous to do so. So those aspects of redo surgery need to be in the hands of experienced providers, and the patient needs to understand the increased risk of redoing, Pectus surgery.
Thank you. We have some more questions. What is the optimal age for the procedure to take place for Nuss procedure for Pectus Excavatum?
Excellent question. So in my practice, I generally like the ages of 13 to 15. And the reason why I think 13 to 15 is sort of the sweet spot for doing this procedure, one, you want to do it early enough so that, remember, this is a progressive deformity. It worsens to some degree, but it worsens as one grows. So you like to intercede at a point before it has fully expressed itself and is as deep and severe as it potentially could be at the end of one's growing lifetime. So I think intervening earlier rather than later is a good idea. But I also think it's important that the patient be mature enough to participate in the decision to undergo the procedure. And I find that doing it in a patient much younger than 13 is difficult, because I think patients 10, 11, 12 tend to not be able to have the sophistication and the emotional maturity to fully participate in the decision to undergo the procedure. But having said that, the youngest patient I've done was age 10. The oldest that I've done was age 53, and all ages in between. That 10-year-old did very well and was a very mature 10-year-old with a very severe deformity, who was very symptomatic and benefited tremendously by undergoing the procedure. But having said that, I think my answer to that good question is 13 to 15.
Thank you. Next question, with the number of patients you have operated on, how many female ratio to male have you done? And any concern about breast deformity? And having said that, any ideal age specific to female patient for repair?
Great questions. So I've done over 1,000 Nuss procedures. About 25% of them have been over the age of 21. I have done many more men and boys than women, than young ladies and women. However, I think that there are demands that are specific to the correction of women that are different than the correction of men. And I think that women tend to grow earlier, and because of breast development, you want to intervene earlier with young ladies because you want to correct the skeletal deformity to allow breast development to occur on a more normal and corrected skeletal foundation. So I tend to slightly undercorrect women because you don't want to overcorrect and create a more masculinized chest. That's the art of doing women. And you want to intervene, if possible, a little earlier than you would in a young boy because you'd rather correct the skeletal deformity before breast development has fully materialized, because you'd rather breast development occur on a more corrected skeletal foundation. I hope that answers all of those questions that you did. They were all good ones, by the way.
I have more, don't worry.
Sure.
Depending on the different deformities, do you change your surgical approach?
Yes, that's a great question. And yes, I do. And that gets to going to somebody who is very experienced, sending your patients to people who have done this operation many, many, many times. And the reason for that is each pectus deformity is unique to that patient. There's a spectrum of severity. There's a spectrum of different variations of Pectus excavatum that one needs the experience of doing the operation in different age groups, with different variations of the deformity, in order to be skilled enough to tailor make the correction to the individual deformity. There's a lot of asymmetry that's seen with this condition, such that not one size bar fits all. So there's artistry in how you bend the bar, in the judgment in where you place the bar in the chest, and how many bars you place in the chest in order to accomplish your ultimate goal, which is to relieve compression and displacement of the heart. Sometimes that can be accomplished with one bar under the deepest part of the deformity, but often it can't, and that needs to be recognized. That's a judgment call based on experience, and the surgical provider needs to have a broad enough experience so he or she knows when one bar is adequate and when two bars are necessary.
Thank you. Do you ever leave the bars in longer if you do not see the correction that is desired?
I don't think that the interval in which the bar is left is based on getting a better outcome. I think you get a good outcome by shaping the bars in the way that's optimal and placing them securely in the chest where they need to go. What length of treatment, where length of treatment is important, is in not removing the bar too soon while the patient is still growing. So for adults who aren't growing, I leave the bars in for 3 years and I remove the bars. I think 3 years for bars in non-growing patients is more than adequate to achieve the optimal result for that given patient. In the younger, growing patient, it's important to leave the bar in long enough so that any residual growth after bar removal is minimal, so you can reduce the risk of recurrence and avoid removing the bar too soon.
Since some of the chest deformity is associated with connective tissue disease, do you send them for rheumatology clearance to make sure subtle clinical presentation of connective tissue is not missed, especially in children?
Great question. This is how I proceed in my practice. This is how I resolve the connective tissue conundrum. I examine the patient thoroughly and make certain that, in my estimation, there are none of the stigmata of connective tissue disease in terms of gross morphology of the patient's body, flexibility with the joints. And then I ask the usual and customary historical questions. Is there any family history of connective tissue disease in the family? And then lastly, if a patient has a chest wall deformity, I think they need at a minimum an echocardiogram and an ophthalmologic exam. And if there's no family history, there's no gross morphologic findings consistent with connective tissue disease on physical exam, and if the echo is normal, as is the ophthalmologic exam, then I don't send those patients for genetic evaluation. If any of those areas that I mentioned are positive, then that patient goes for testing. And I send my patients to, because I'm pediatric in orientation, I send patients to geneticists and dysmorphologists. But rheumatologists are often quite well versed in connective tissue disease and are very comfortable working patients up more thoroughly for connective tissue diseases when there's suspicion that there may be such a diagnosis.
Two more questions. What is the rate of reoccurrence?
So in my practice, doing the Nuss procedure for over 20 years, to my knowledge, I've never had a recurrence. I've never had a patient come back to me and say, look, I'm sunken again. I just haven't had that. So I think doing the operation well, doing it often, following the training and guidelines that have been established by first and foremost Donald Nuss and those of us who have been doing this, for decades. If one does that, one should not have recurrence. It's just not part of the potential problems that could exist following the Nuss procedure.
What are the biggest risks or surgical risks for the Nuss procedure?
Great question. I would say, in my personal experience, the most common problem are problems related to fluid collecting in and around the bar after surgery. So seromas and hematomas, those kinds of problems are rare, but they do occur. Probably in the range of 1 to 2% of patients, not very high. And most of those problems can be dealt with non-surgically. Some you just allow the body to resorb the fluid. Sometimes you have to aspirate the seroma or hematoma that can develop in and around the bar. But generally, it's not a major problem. The most common major problem that I see in my practice is infection. But infection in my practice is less than 1%. And I think that involves meticulous sterile technique, as should be the case when one does any surgery that involves implantable devices and hardware, using prophylactic antibiotics for a period of time perioperatively, and minimizing trauma to the tissue as you're doing the procedure in concert lowers the incidence of infection. So, I may have an infection 1 every 2 years. And most of those infections I treat purely with antibiotics. It's the rare case that you have to go back to the operating room and do some, surgical wound revision in order to treat the infection. Most of the infections are treatable with oral antibiotics. Sometimes it does require readmission to the hospital and IV antibiotics for a period of time, but that's the exception rather than the rule. Anytime you implant, a device in the body that's made by human hands, there is a discernible, and fairly consistent incidence of infection that occurs from that, no matter how meticulous you are. But we've reduced that to a minimum. In terms of major complications like injuries to the heart, to the lungs, displacement of the bar, those complications shouldn't be occurring at all. I've never had an injury to the heart or to the lungs. I've never had a bar displace where I have to go back in and re-anchor it or stabilize it. Those are problems that shouldn't occur, in my opinion, if the person who's doing this operation is experienced and skilled.
Should I refer in infancy if noted, or wait until old enough for PFTS?
Great question. And here's my advice. As someone who's been doing this for a very long time, I think it's helpful to families to meet individuals like myself when the diagnosis of a chest wall deformity has been established, such that the family can be reassured by the person who is most experienced as to what the life journey might be like for that individual. I think it's comforting for most parents to hear from the expert that a patient who has a Pectus Excavatum deformity at a month or 3 months or a year of age can have a normal life, should be encouraged to be active and engaged in all aerobic activities that the child is in. and that ultimately there's a resource to evaluate that patient and determine eventually, at some point in the future, whether or not correction is indicated. So I like to see the patients as early as the pediatricians want to send them to me. It allows me to get to know the child, get to know the families, and to meet with them, on a biannual basis or every 3 years when they're very young, and watch them mature and become, part of the child and family's, medical team going forward. It builds confidence, and it builds a relationship that really can be quite helpful later in life when the child is found to have a deformity severe enough to warrant correction.
Few more questions rolling in. Do you send patients home with an antibiotic after discharge from the hospital?
I don't. That's an easy question. I don't. I keep them on antibiotics for the 2 to 3 days they're in the hospital, and then I discontinue them at the time of discharge. So the answer is I give them perioperatively. Before surgery, as the patient is being induced, and then for 48 to 72 hours after surgery.
What is the threshold to consider surgery to correct Pectus Excavatum besides cosmetic appearance?
Well, I would say what we covered in the lecture specifically would be symptoms. So in a perfect world, you'd have a patient who's symptomatic, most commonly shortness of breath and exercise intolerance. You would have someone who has who has a significant severity score, which is greater than 3.25, and has some physiologic validation that there is compression and displacement of the heart that is significant, which would be a metabolic, stress test, which shows abnormal VO2, or you would see on the cardiac MRI an effect on right-sided heart circulation due to the compression and displacement of the heart. And you would also have a patient and family that say, we want to go forward. We believe that doing this operation is going to improve the quality of my child's life, and as the patient, it's going to address issues of concern to me, both physiologic and cosmetic. That's going to add quality to my life after the deformity is corrected. So I'd want as much of that in place as possible before moving forward.
Looks like this is the last question. What are Nuss bars made of, and what happens if the patients are allergic to the metal bars?
Well, that's a great question. The bar is either stainless steel or titanium. As I would say, most specialists in this area have all of my patients undergo metal allergy testing. Okay, that's skin testing for metal allergy. And they test for the most common of which is nickel, but they also test for chromium and molybdenum and titanium and all the other alloys that go into the makeup of stainless steel. And if you're allergic, which approximately 10 to 15% of the population is, then once identified, a titanium bar is used. And if one goes through that process of allergy testing, and if positive, titanium bar implantation, the incidence of metal allergy complications for the patients should be zero. Zero. So metal allergy as a clinical entity becomes a worry not worth having, because the testing has been done and the alternative has been used when metal allergy has been identified. So allergy, bar allergy, should not be a problem in a program where this protocol is followed.
I think that's all of our questions. So thank you, Dr. LoSasso, for a great lecture and discussion. And thank you for all of our attendees for taking the time out of your busy schedules to join us. Take care and have a great evening.
Thank you, everyone. Stay safe, and thank you for spending time with us tonight. Bye-bye.